So let's turn it over to Dr. John Scott, Professor of Medicine in the Division of Allergy and Infectious Diseases and Chief of the Digital Health Office. He's the Chief Digital Health Officer for the University of Washington Medicine. John, over to you, please.
Thanks, John. So what I wanted to do is share what the state of Washington and specifically the University of Washington is doing around hepatitis C virus elimination. And just to kind of go over what I'd like to talk about in the next 15 minutes together, start out with a little bit of the background of the EPI for the state, talk about the Hep-Free WA program, and then go through some various programs that we've rolled out at the University of Washington and also at the state level. And then finally wrap up with a recent survey that one of my colleagues did to elucidate some of the barriers we have currently for screening and treatment. So I think similar to other parts of the country, the incidence of hepatitis C has been dropping. So on the left-hand side, you see in blue the number of new cases that are being reported to the state. They've been dropping steadily. And you can see in red the comparison to HIV, so quite a bit higher still. On the right-hand side is the data from King County, which is the most populous county in the state of Washington, accounts for about 1/3 of all Washington residents. And what you can see in the bar graphs is that the prevalence has actually started to go down a little bit. And with that, the number of new cases has dropped. Some of that might have been a residue of the pandemic. But the thing I think is encouraging is to see that red line, which is the presumed cured, really start to tick up. Part of this is better tracking, but also I think that there's a number of other interventions that have taken place in the last 5 years that have really helped to speed that along. So we're optimistic about these lines crossing here. So that leads me to the Hep C Free Washington initiative, which was kicked off by our Governor Inslee in 2018. And the mission of Hep C Free WA is to eliminate hepatitis C in Washington State by the year 2030. I think Governor Inslee was one of the first governors in the United States to envision this as a solution for Washington. You can see some of the principles there, but I want to talk about some of the key aspects of it. The first was a statewide negotiation of the price of directly acting antivirals for not just Medicaid recipients, but also the public employees of Washington State, of which I'm one, and also all the teachers in the state. So that accounts for a lot of patients in Washington State. And so we have a very low cost compared to other parts of the country and commercial insurance for access to directly acting antivirals. Other key components of it is just tracking that data. So we have a dashboard so we can kind of see how we're doing. We have DIS officers, folks who are investigating these reports and making sure that they're getting linked to care. And so I think that that has been an encouraging and successful program. So one of the things that we've had available to us in Washington State is Project ECHO. ECHO stands for Extension Community Health Outcomes, and I was fortunate to start that in 2008 with funding from the Robert Wood Johnson Foundation. For those of you who are not familiar, this is a case-based telementoring program similar to Morning Report, like we were educated on as trainees. And so we gather once a week by video, and we usually start off with a didactic, and then we hear cases, and usually hear 3 to 6 cases over the course of an hour and a half. And the key aspects of the program is that we have multidisciplinary panelists, so have hepatology, I'm an infectious disease. We have folks who are experts in addiction medicine, and we're primarily working with federally qualified health centers and rural health clinics. We have all kinds of learners and participants. Usually they're primary care providers, but sometimes it's pharmacists, mid-levels, nurse practitioners, PAs, and the occasional medical student and specialists who join them. So since our starting in 2008, we've heard over 25,000 cases, and have reported outcomes in both the interferon era and the DAA era, and it's very similar to what you'd see in phase 3 clinical trials. So that has been a great way to reach some more remote and rural parts of our state. I'm thinking right now we have about 20 to 25 regular participants in Washington, and then probably another 5 to 10 around the Pacific Northwest that would join us regularly. The second thing that I wanted folks to know about is the online curriculum that has been developed by my colleague, Dr. David Spock. Here's the link on the lower left. If you're interested, this is a program that was sponsored by the Centers for Disease Control. And it has a curriculum where you can walk through, go through the epidemiology, diagnosis, and then treatment. They have over 1,000 slides that are free and people can use if you're going to be giving a talk. And it has all the relevant trials so folks can have those for reference. And the last thing that I use quite a bit is just the clinical calculators, so like the APRI and FIB4. It's a great resource there. They have a similar one for hepatitis B as well. So in 2014, we were the recipients of a CDC grant to do population-based screening and linkage to care and treatment. And one of the most important things we did was just to try to make it easier for providers to do the testing. And so one of the interventions was at Swedish Medical Center, which is one of our large private hospitals in Seattle. And they're on Epic, and they just created a HCV screening initial management smart set so that the providers could just kind of pull this up and make it easy to order them the relevant tests. The other things that were done at other institutions were best practice alerts. So I know that sometimes those can be annoying, but these actually worked. And also we sent portal messages to patients who were in the baby boomer cohort. And then when the CDC recommendations changed to screening all adults, that also triggered an alert and also led to a surge in testing. And the last thing that our colleagues in the FQHC did was just having orders pending for testing. So the doctor didn't have to get prompted by another staff member. There was usually a medical assistant who would ask people who are in the relevant age group if they wanted to get a test, and the order was already there for them to go down the lab and get that done. So this is the data from that study. On the left here are the percent of folks who were screened in this is baby boomer cohort. And you can see at baseline it was pretty low, and at the end of the study it was over 50% of folks who were eligible for screening were getting screened. And I think the most important part was that it improved the whole care cascade at every single step. So of those people who are RNA positive, they were getting appropriate staging for treatment. They're getting access to care. And then the SVR rate was 95%, similar to what we see in many of the phase 3 studies. So I want to talk about some new innovations that have happened in the last couple of years. And this is really a result of realizing that many of the patients who have Hep C today really struggle with access to care. And so instead of asking for them to come into the clinic or come into a hospital for care, we're going out to them. So one example is the SHE Clinic, which is a low barrier walk-in clinic for persons identifying as women in North Seattle. This is an area that is known for having a fair amount of commercial sex work and also injection drug use. And they're partnering with a nonprofit called Aurora Commons. So they provide a daily meal, coffee, mail services, and a safe space. And they have started limited primary care with chronic disease management. This is a shot of one of the rooms there. They offer STI testing and treatment, including HIV, viral hepatitis. They also provide PEP and PrEP and medications for opioid use disorder and wound care. So that's just one example. There are 2 other sites with this kind of model around King County, more in South King County. And then at Harborview, the sexual health clinic, which is a walk-in clinic at Harborview, does screening and also can expedite treatment as well. So the other innovation that my colleagues at University of Washington has done is to really lean into our colleagues in pharmacy. So we partnered with a community pharmacy that had done quite a bit of treatment for STIs using a CDTA. And so they had experience of prescribing for chlamydia and for PrEP. And so this was a program they were in a model they were familiar with. And what we did is we developed a pharmacist, physician, and patient navigator collaborative care model, or PPP-CCM for short, to deliver that HCV treatment. This occurred primarily during the pandemic, so there was lots of challenges for that, but we were able to enroll 40 people who injected drugs. Their mean age was 44. Most of them were men, and about 40% were unhoused. And you can see on the right here is the care cascade for that model, where 95% of the people who were screened through a patient navigator were then linked to a pharmacist, and then 55% initiated treatment. 76% completed therapy, 70% completed SVR labs, and 91% achieved an SVR. When we surveyed the participants in the program, both the pharmacist and the patients all reported a high satisfaction with this model, and it is a program that we're hoping to expand around the state. So lastly, wanted to talk about a survey that my colleague, Paula Cox-North, conducted during 2022. This was a survey that was sent to all Washington State providers, including MDs, ARPs, and PAs, and clinical pharmacists. This is just a high-level overview of her findings. But they found that of the 554 respondents, the response rate was pretty good at 28%. And many of these providers are offering screening, so 96%, although a lot of them are just sending it down the lab. There's not a whole lot of point-of-care testing. There's still quite a bit of referral to specialists. 71% were relying on our GI, hepatology, or ID colleagues to actually do the treatment. And when they were asked why they weren't treating themselves, the most common reasons listed were just a lack of organizational support, and unfamiliarity with the billing and lab services. For those who were not treating, they also cited inadequate knowledge. And again, going back to billing as a big barrier. There were a couple of questions exploring stigma, and fortunately it was pretty low, but this was reported. 5% of the respondents reported an unwillingness to treat patients with HCV, and 8% saw inferior care of those patients who had hepatitis C. So still some progress we need to make there. So I just wanted to summarize some of the
recording in progress.
Some of the things we're working on in the state of Washington. I think having a governor to lead this effort and having that political will and having a central organized body was really important. It also underlines the importance of a partnership between public health, state government, academia, and the community. The pan-genotypic regimen, which was affordable for our medicated patients, was key. And it feels like provider education and that democratization of knowledge that we saw in Point Deco has been a huge driver of success. Don't forget to support your providers with the simplified processes and the ancillary staff. And I think as we see the current generation of hepatitis C patients and their challenges, we kind of have to rethink our care models as those patient characteristics and challenges evolve. And with that, I just wanted to acknowledge my colleagues, especially colleagues at the Department of Health, John Stockton, Amelie Rowe, my colleagues at UW, Jeff Dushin at Public Health King County, and of course, John Ward for all of his advocacy and support of this work. Thank you.
Thank you, John. That was a great overview of a longstanding program and some of the key, success factors. One of the adages in disease elimination is that the last 10% are harder to find and cure than the first 10%. And I just, with that, decreasing, prevalence and, how do you sustain interest in this program, or, the focus on testing so that you can really, complete the journey toward elimination? Do you have, any strategies to share?
Well, I just think it's keeping it in front of people, especially my colleagues. So just trying to remove any barriers in their mind, and making just the screening simple. I think that's probably the most important thing is trying to use technology, the EMR, to simplify physicians' lives is probably one of the most important things. Because we're just busy and we don't always think about it. So if there's things that can kind of help us remember to do this testing, that'll probably be my takeaway advice.
Yeah, and then quickly, it looks like people still refer patients to specialists rather than doing the treatment themselves, even though, with the MinMon study and others showing that it's, very implementable for primary care. Why do you think that referral still happens?
I think it's probably just kind of what they've always done, and maybe some people just don't know that they can do it. So when I've seen echo work, it's usually one provider in a FQHC who will take all the referrals within that FQHC. So we don't have to get everyone. We just need to get one or two providers in a community to do this. We do have some treatment deserts where there really are no specialists able to take that, and so we're working with DOH to identify those areas that don't have access to specialists and trying to build it up through ECHO and some of these other initiatives.
Very good. Thank you.